Hi, this is Walt Fritz from Foundations of Manual Therapy Seminars with the next in our series of evidence for manual therapy for the SLP. This time we're taking a look at a 2022 paper by Holly McMillan et al. Titled Manual Therapy for Patients with Radiation-Associated Trismus After Head and Neck Cancer. Been an advocate for manual therapy for most of my professional career, and as I transition into the teaching this work to speech pathologists and related professions, we get a lot of different diagnoses that I hadn't encountered in my days in physical therapy, or at least the circumstances that led to those diagnoses. And there's a more ample evidence for manual therapy's uses with voice disorders, dysphonia, etc., than there is with head and neck cancer related issues, dysphagia, trismus, or at least historically. More recently, there's been a lot more, including this, what I consider a really well done study. Of course, I like it because it kind of scratches my biases, but what I really appreciate about this study is that they take a look at not just of the tissues themselves, but the kind of the posture, if you will, the way a person holds himself in the head, neck, and shoulder, and address that in this study. One of the key points of this study to me, when we get to the conclusions of the paper, is that it shows that manual therapy can improve maximum mouth opening in head and neck cancer related trismus in a significant way. A couple of key points. One is that the first intervention session by the clinician, in terms of doing some of the manual therapy intervention, improved the maximum mouth opening to the greatest degree. And I just find that really inspiring for clinicians, whether you're new to manual therapy or been using it for a while, that from that first session, you and your patients are going to see the most significant change. Not that subsequent sessions can't help, but that first session is going to be very impactful for them to see a reason why, first of all, they might want to continue treatment by you, but also learning the techniques themselves in terms of a home program, why it might be in their best interest to continue using those on a regular basis, because we know the effects of the radiation fibrosis makes it so it continues to be an issue that sort of recurs, that we may not be able to ever help that person in terms of, okay, you can open your mouth normally now, you'll be good for the rest of your life. But if you can give them that stimulus, that impetus to say, this is what's possible if you continue with this, that is a really good motivator for self-care on the part of the patient. Another thing that the conclusions draw out is that this is also applicable to our long-term patients. In the study, they quote patients with 5 years or longer post-treatment still have the potential to benefit from manual therapy. It's a question I get frequently, both online as well as my seminars. Well, how late is too late? Well, it might not be too late ever to at least try to initiate this. If you go into the supplemental materials on this particular paper, you'll see, the procedures that they used in the study to not just to rule out things, but where they worked, how they worked, etc. I do have one bone to pick with not just this study, but almost every study. They really don't tell you what techniques they do when it comes to the research, the evidence for manual therapy, sometimes for exercise-based interventions too. Sure, there's an allusion to certain interventions, and if you're used to manual therapy type of studies as well as work, you might be able to interpret the results. But I do wish that authors could do a better job in actually giving us a list of what they did, so that we can take that evidence and actually apply it with the patient and really feel that we're following the basic tenets of evidence-based practice. But that's a very small bone to pick with the authors, who I commend for the study that they did do. They also talked about visit frequency, tolerance, what sorts of things they needed to tailor and modify based on individual patient characteristics, which I think is absolutely crucial. We sometimes create these studies, or we read these studies that, and it's basically, an operator saying, here's what I'm going to do to you. And instead of the realization, that's an interaction. And we have to base it off of what a patient tolerances, preferences, and our own tolerance and preferences too. I know that sometimes gets a little fuzzy with research models, where you feel like we have to be totally objective, rule out all variables, and make every single intervention the same. But what does that lead us to when we get into the clinic and a patient can't or won't tolerate things in the way that, well, maybe the previous person did, or maybe the study says? We need to be flexible with that evidence, with the techniques, to really respect that in the individuality of a patient. So again, I'm really fond of this. I think it supports a lot of the work that I teach in my work, as well as a lot of other really good fine manual therapy education for speech pathologists, but in general. You can read, if you're interested in these papers, you can read both the paper itself, full text paper, as well as the supplemental material, which I think is pretty important, from my website. I'm going to give you access to that paper, and you can see the link here. And if you use the password Foundation Seminars, that'll get you in to be able to catch up on this paper, as well as dozens of others that I posted there. So I hope this helps you in your journey figuring out, is manual therapy appropriate for the speech pathologist to begin applying with their patients?